So hopefully some of my older friends again and some of my new friends are out there. Peter from Ontario Health, Peter Papadakos. He's the Director of Business Intelligence and Analytics for Ontario Health. Paul Sandor, Director of Decision Support and Coding and Health Records, and probably a couple hundred other things from Hamilton Health Sciences. And then Evelyn Piper, the Health Strategy Lead at Roche. Very first time meeting in person, so very nice to meet you. These guys I've known for years. And then I get to be the moderator for this session. And so the topic is on the journey to a harmonized health data landscape, aligning local and regional data strategies. And so as I reflected on this topic, I'm thinking, okay, you know what, Canada, we got 10 provinces, 3 territories, I think last time I checked. So that means we probably have 13 health systems, one would like to think. But then I reflect on Ontario, and I'm like, wait a minute, okay, well, we have like a Northern Ontario cluster, right? And then we have like a Hamilton bit of an area kind of cluster, and we still got a cluster going on out east in the Ottawa region. So again, probably already have 5, 6 different health systems within Ontario. And then all of a sudden we have groups, and I know like this is no offense to anybody, but we have groups here today from Canada Health Infoway, CDA, right? The Canadian, formerly CADIT, right? We also have CIHI that play roles, right, nationally. Then we have Ontario Health, where subsidies are subsections of Cancer Care Ontario, right, and other kind of renal networks that are still within there. Then you've got the private guys, right, the guys that work at Johnson & Johnson or the girls that work at Roche, who also have data and have needs and access to data. And so let's think about how do we begin to even start to harmonize this? So maybe we'll start, ladies first. Introduce yourself and tell us a little bit about your organization.
Yeah, happy to. Nice to see everyone here. I'm Evelyn. I'm a health data strategy lead at Roche Canada, also a part-time PhD student at the University of Oxford. And I think the perspective that I bring here, wearing my Roche hat, is really like the end user. For the most part, in my day-to-day, we're relatively far away from the problem and even away from the hospital system as data end users. And so I think the perspective that I bring here is more so of like thinking about the macro level impact of a disconnected data system that we have today. So I think most folks in this room would be acutely aware of the in-the-moment patient and provider level impacts of disconnected data, right? If we have a patient who moves from one jurisdiction to another, or, God forbid, from one province to another, where does that data go? Does it move with them? But what's particularly relevant for me in our day-to-day work in real-world evidence and essentially evidence needed to get new medicines available in Canada, the impacts of disconnected data go so far beyond the patient in that moment and impact the patient in their lifetime journey and availability of treatment options. And so I'm sure we'll talk a bit about this later, but essentially, like the biggest impact that I see is like our ability to understand unmet needs in Canada, to understand the treatment landscape, are really prohibited by the fact that we have these disconnected systems across provinces and within them. And so that prevents us from being able to make the case that certain patient populations, certain regions are in need of other options. And our decision makers, CDA, Health Canada, payers, they can only make decisions off of the data that we provide to them. And pivotal trials are key, but we know that we need real-world data on Canadian patients to really provide a compelling story. So I'll cede my side of the conversation with that, but I'm sure we'll talk about that a little bit more.
Perfect. Next we'll hear from Paul. And Paul, I know I lived your shoes. I'm curious to know, how much has it changed in the last 10 years?
That's a good question, Jonathan. The technology has certainly changed, and I think as you experience that multiple times, you quickly become tool agnostic, and you become anchored. You anchor yourself more in, what's the punchline? What do we need to get out of the data, et cetera. But I would say, perhaps I see more things that haven't changed than have changed, perhaps. And one of them is the breadth of the data landscape. Well, maybe it is changing in that it just continues to grow. But what doesn't change is wrangling in that context, that vastness. Aspirationally, we'd like to be able to say that, or have eyes on all things as being complete and valid, but there's a practical boundary to that. And what that kind of sets the stage for is a bit of a Schrodinger's cat situation where the cat is data quality, and until you have a defined use case for some data, the data quality may not be there. And then you have to iteratively, kind of go through foundationally, how do we get that data on track? It takes time, it takes resources, and that's the thing that I think hasn't changed.
So I realize I kind of diverted the question
That's
there.
okay.
So going back to, okay, so you work at a hospital. Tell us a little bit more about, so when we think about the topic of aligning local to, to national or beyond, what's the lens that Paul looks at?
Yeah, so, my current role, Hamilton Health, it kind of reflects the entirety of my career in that it has spanned both the data space and the analytics space. So in my current role, I have a breadth of teams upstream and in the data space is coding, health records, MIS, case costing, and then downstream, all of the decision support space, the integrated analytics provisioning space. And it gives me a balanced lens on what the upstream lift is to make sure the data is fit for use and it's accessible, et cetera, all of those good things that we want to check the boxes for. And then downstream, living okay, so once the data is there, at the back end, we want to make sure that we have, robust processes for intake, triaging, prioritization, and making sure we're provisioning things as effectively as we can in an environment ultimately of very constrained resources. So, which is to say, to your question, that, the lens I bring, it doesn't matter if you're talking the data end or the analytics lens, my mind zooms out holistically to look at the entire equation to say, well, where are you on that, and what are the upstream and downstream pieces of the equation I can kind of bring into the discussion to make sure we're setting people up for success.
Perfect. And now to Peter, Ontario Health.
Thanks. Peter Papadakos, Director of Analytics at Ontario Health East. I have a background in hospitals and other provincial organizations. Started at Sunnybrook, went to Cardiac Care Network, now Core Health, then back to the hospital, UHN, then to the Ministry of Health, and to Queenie Healthcare, and now back provincially at OH. And data strategies interested me for quite some time, and I've helped implement data strategy at a couple of institutions. So it is a huge undertaking, as VHA showed earlier, the amount of work they're putting into their data strategy. Making sure your data assets are of good quality, they're aligning to the corporate strategy as well, understanding what additional data assets you might need in acquiring them. So it's a big job. Within an organization, I would say it's a lot easier than doing it on a provincial level or a national level, like you articulated at the beginning. And I think my eyes were really opened to the need for, some seriousness around a data strategy for Ontario or for Canada when COVID hit in late 2019, early 2020, when there were huge data gaps noticed. So some data was really poor quality, some data we weren't even collecting to report on, to predict, when is the next flow coming in of COVID patients. And interoperability as well. Organizations had a lot of trouble sharing their data. So private AI, who was up here earlier, mentioned we're only using 80% of the data that we have. And we know that some uses of data can cause harm, but it can also cause harm not using the data. So I think that we really need to get on that and start utilizing this information that we have.
So I think there's probably a lot of people who would agree with that statement. We need to get on that, right? So let's think about the journey. What's the first step? Maybe we'll go in reverse order. So we'll start with you, Peter. What's the first step we take?
The first step.
And what can we do here today at this conference?
So there was a pan-Canadian data strategy that started being developed in 2020. So I think starting to implement some of that would be helpful. So one of the big things is interoperability. So it isn't really a technical issue. It's more of a structural and a cultural issue, right? So what policies are in place, what standards need to be developed. And then culturally, across various institutions, they're at different levels of maturity. analytically, they have different health information systems. So I think building out that culture side is really important. So engaging patients, providers, increasing communication to try to build out the shared understanding. How do you increase the literacy in the public and in our institutions?
Maybe to you, Paul, next. What's the first step we could take? Is there a step we could take today?
Yeah, well, I'm going to zoom in on one of the underpinnings that Peter mentioned in the strategy context, and that's standards, which is, if I think of spaces, where do we have good standards? At a pan-Canadian level, we have CI-High, very clear standards around coding. Not that that makes the data quality journey and a complete at all times, but it's an ongoing journey. But everyone has a touchstone. We know the data we're getting from all hospitals is like in that regard. If I go down to the provincial level, we see MIS standards. So from a financial and statistical lens, these are defined standards that all of the local entities can look to say, okay, what do I need to be thinking about? So that when we bring in the interoperability piece and the data's flowing from everybody, is it like data or not? So now let's look at where we don't. Thinking beyond CI-High and MIS. So now we move into the, we're deep into the EHR, space at this point, and there's, I referenced the vastness of the data. It just continues to grow. But we don't see like standards being stood up. And I think, ultimately the question becomes, is that a regional, does that go to the regional level? Should they be accountable? Is there a pan-Canadian level where we bring in standards? And it could be down to things as simple as, surgical cancellation codes. So there really isn't a standard around that. So if you're looking from a regional planner lens and you want to understand what's going on with OR utilization across regions or sub-regions, and get a sense of where is there a high cancellation rate and get an understanding of what's driving those. In the local entity space, there's no standards for how to codify your cancellation reasons. As much as we're at Hamilton Health, we're in Epic, so a very evolved EHR state, and yet the data field to collect that is cringeworthy free text. So how do you get from free text? And I know we've got AI and other things, but those only work if everybody fundamentally, when they're entering that free text, has a grasp of what are the 3 or 4 things that I need to reflect in that free text. And that's just not there for that and many other things. And that's kind of connecting back to my earlier comment. That's where it's kind of the use case drives what's next to tackle.
Yeah. It's funny, 2 things that I reflect on that was the first one. Somebody mentioned earlier is like don't use abbreviations, right? Like that, great standard. Like we should adopt that everywhere. I think about that even within our own personal data. And then there's something else you said. It's just because you have standards doesn't mean people follow them, right? That's the other challenge that we're going to face too. So over to Evelyn. So as a stakeholder, and you're hearing this, what do you think is the first step?
Yeah, the first thing that came to my mind when you asked that was kind of alluded to by Peter already, which is the cultural aspect. So trust, like the first foundational step feels like it needs to be trust, because I think we can all be guilty, whatever hat we're wearing, of taking a very data protectionist view to all of this, of we have data, no one else should see this data we have. But I think we live in a world today where the level of we've advanced the way we're able to protect privacy and de-identify data, and I think that that's employed across so many sectors that I do think we need to, as a healthcare sector, be thinking critically about, are we protecting data for the sake of protecting it, and to the point earlier, what harms is that creating, rather than deploying the available technology to ensure that the privacy is protected, but data can be used for research purposes and for a variety of other secondary sources. But I think beyond that, maybe the less technical and practical first step, but more philosophical, is reorienting what are we trying to solve with these changes today. And I know one of the questions earlier or comments was around the workforce changing, and often something I think about are the things we're trying to solve for today in terms of data collection at the hospital level or at the system level. Is it trying to rapidly solve for problems we've been facing for 10 years, or are we trying to reimagine what we need to do in the future, and maybe that's a system that's more preventative versus treatment focused, and maybe that's not centering data decisions around what today's HCP, healthcare provider needs, and more about, well, who are the healthcare providers of the future going to be anyways? Because AI is going to change all of our jobs, and so what do those folks need, and what can we start to lay the foundation for now? So yeah, maybe a more philosophical view, but it feels like a lofty first step.
No, absolutely. Paul, I saw you kind of nodding your head. Any reflection on that statement, or?
Nothing specific, but kind of riffing more on your comment about just because there's standards doesn't mean the data's good. And so I kind of referenced the standards in the context. There needs to be some regional leadership in that. At the local level, though, then there needs to be the local leadership to say, how do we live to those standards, and what does that look like? And is it policy? Is it culture? Is it iterative renewal around surveillance, mitigation, or remediation and mitigation, et cetera? And I think that's where you start to drift into what are the local strategy accountabilities that we need to think about to align with standardization.
So, Peter, as a regional lead, then is this all falling on your shoulders? Is this what it sounds like? Is this
Oh, yeah, I have a huge burden, huge burden to bear.
So reflection on that is regional level the right level to start? Is that the most tangible? I think it's a step, right? Perhaps, or does it come from local? And maybe we could reflect on what's the role of the private side of this, and what role can we play?
Mm-hmm. Yeah, it's. I think we almost need a national harmonized standards, but they shouldn't. And it needs to be federated as well. So policies, standards, all of that. And then I think that that general harmonization has to cascade down. But each organization and region and province still needs to be independent to do what they want to do, or otherwise you'll stifle innovation, things will slow down. There's organizations at different maturity levels, whether it has to do with their data quality, or their analytics capability, all of that. So I think there needs to be a harmonized approach to it, so we're all beating, the same drum, at the same rhythm, but allowing for that independence to foster innovation and let organizations grow at their own speed.
Yeah, and Deepak alluded to that earlier too, right? It's just how do we, recognizing the fact that some organizations specifically on their strategy map have said, you know what, we are funding AI, we're investing in AI, and meanwhile, I know that there's hospitals who are, having to make tough decisions this year around laying off nurses. And so, and how do we, and I don't think we have those answers, but, these are all things that are considered, right, in terms of that. I think we'll go back to, what is the role of, standards in terms of do we start with a minimum data set? Is that you would think is that a good launching point, or? And then if it is a minimum data set, is that different than what we do with Kai-Hi, or is it, I don't know, I'm looking for reflections on that.
Yeah, I think what is the common vision, let's say? It could be, always improving, patient-centered, and a learning health system, right? So if that is a common vision where we take primary use data, push it to secondary use as a learning health system, insights back to, the insights, the research back to providing care, can you take that common vision and create a minimum data set?
Yeah.
I'm not sure if you can, it might be too broad.
Yeah, well, and I think in healthcare too, we still have things it started as the triple aim, right? Then it was the quadruple aim. Now I think it's the quintuple aim. So I think that is the guiding light, right, for any effective and high-performing healthcare system. Mm-hmm. But at the same point in time, that's a challenging thing to achieve, right? If you don't know, I'm not going to go over the whole triple aim, quadruple aim, but I think most people here know it. Reflections.
Yeah, I think when I think about our biggest challenges and when we're doing research studies using Canadian data, it's actually often what's going on outside the hospital where the biggest gaps are. I think of the DAD and NACRS data sets, like the CHI standardized sets, it's not as challenging for us to get a multi-province or national view of what's going on within emergency departments and hospitalizations. But I think we know that that's just such a small part of a full patient's journey. And so where we kind of deal with complete unknowns is often in like what other treatments are people getting outside of hospital? What about in outpatient visits? What about specialty clinics? All the other comorbidities someone has that don't take them into the hospital itself. And so I think that while a lot of folks' roles, and particularly in this room, I imagine, are focused on these core hospital centers, I think to not have all centers or pharmacies be at the reporting standards of a hospital really limits, I think, research, ability for patients to be recruited into clinical trials, et cetera. So I think my interest area would be how do we fill that black box that is treatment data and specialty?
Peter, I know you and I were kind of smirking at each other there.
Oh, yeah.
I don't know if you're thinking the same thing I'm hearing, but I'd like to hear what you were thinking.
Yeah, I was just thinking it goes back to that interoperability question again, right? And how do you get these primary care data sets or lab data sets that would be so valuable to you? And it's definitely a huge challenge to do that.
Yeah. Well, and again, it's going back to the whole role of public health, right? Or the whole role of all these external agencies that are now playing a bigger and larger role, because not everything can happen in a hospital. We have to rely on all these different things. Paul, was that you raised your hand, Paul?
Yes, it was.
Okay.
Yeah. No, before we moved on, I just kind of want to circle back again to your suggestion of a minimum data set. I think the notion of that resonates from the lens of let's not try to boil the ocean until we've landed a robust playbook on how we go about this. What form that MDS takes, who drives the content, et cetera. I think that's for broader discussion. Yeah. But I do think that, to Peter's comment that the hospitals are all at different stages. So if some are focused more here or there based on their own internal use case priorities, the only way we can kind of get them all aligned behind common things is to have some external, starting point to build from.
Yeah, and I think from a data literacy perspective, it's important to get the patients, providers, everyone to create that playbook. It shouldn't just be created by a government institution. It needs to have a lot of feedback into what's important for my health.
Well, I know we're going to hear later on this afternoon, right, from some national organizations, right? Because I'm sure there's some people nodding in the audience going, we already do that, right? Or that's already existing, right? But I think that's where how do we stay attuned to all that shifting pieces, right? And then that changing environment and stuff like that. Before I go to questions from the audience, I want one last thing. So I think if we look back, say 5 years ago, this was before my time with AWS. Technology was a barrier, right? I spent some time working with AWS and recognized technology, in my opinion, shouldn't be a barrier. Do you agree with that statement? We'll start with Evelyn.
It's no longer a barrier
It's no longer,
today.
yeah. It's no longer.
Yeah, I don't know. I do think the conversations that I've had throughout this year, as we've been talking with policymakers, data scientists, they're about how do we begin to solve this connected data problem. It seems like everyone comes back to cultural over technical. It does seem like it's the thing that's we're getting in our own way in Canada. And I think certainly if we dig into technology, what that means a little deeper, of course, resources will always be a thing. We can't all deploy the best version of every technology as it comes out. But I think the notion of it exists somewhere, there's probably a solution that exists somewhere for most of the problems we have, I would say is largely true. But I do think that it's so much harder to overcome the cultural challenges and how we all work together.
Paul?
Yeah, I don't know if we're ever done with how far the technology takes us, but I think, I think inarguably it's better than it was, for sure. But I would say, much like your comment about standards, just because the standard's there doesn't mean the data's good. Just because the technology is a greater enabler doesn't mean there's not still foundational work that needs to continue to make sure the data being fed into that technology is accurate.
You agree?
Yes. Yeah, and I think the other piece is the structural piece, right? So it's the cultural piece and the structural, which is legislation, PHIPAA, different privacy legislation across Canada. I don't know if you can speak to CPPA. So I think that legislation is being proposed, which would give own data back type legislation, which could help. But I think it's primarily structural and cultural.
I'm going to open it up to questions to the audience. There's got to be some questions out there. Oh, there we go. There's a mic.
Thank you.
Maybe introduce yourself to it and let us know where you're from.
Yeah, my name is Jonathan. I'm from Munich Re. So we work with electronic health data from the US in a life insurance underwriting context. I noticed the panelist was talking a lot about data interoperability, and one of the, I guess, cornerstones of our offering is we have developed an approach to migrating CCDA format EHR records into the FOST interoperable healthcare resource framework. And I'm curious, that FHIR framework was mandated in the US, but I haven't really heard anyone speaking much on that from a Canadian perspective. So I'm just curious, are any of the panelists aware of the FHIR data model, and kind of what are the contenders, if you will, in that space at the moment?
I know some hospitals use FHIR. I don't believe it's mandated here, though, and I'm not sure if it will be.
Paul, any experience with FHIR?
Yeah, I mean, I do see, some net new data submission feeds coming from the ministry side where they are building them around that FHIR spec.
Yeah, so I think that it's coming, right?
It's
I think
evolving,
yeah,
but it's
I
not
think it's evolving.
mandated, so you see it in bits and pieces.
That would be my suspicion as well too. I know when I was a couple of years ago, or when we were thinking about how it was, I think it was HL7, if I recall, was the standards before, and then FHIR was the new kind of minimum data standards. But I think it's still very premature. Would be my reflections. But again, we could talk about that more later. Any other questions out there?
There's one right here.
Oh, there's one.
Hello, everyone. Thank you, Jonathan, and the panelists for a great discussion. I am Elena Lungo. I'm with Canada's Drug Agency. I lead the data and analytics function. And I have a question. We've heard earlier today, and I apologize, my voice, I've lost it last week. We've heard kind of earlier about how the various healthcare delivery settings are leveraging data to improve their processes. And how the various regions and ministries are kind of leveraging the data to inform their decisions. My question is, kind of looking at that vertical integration, do we then take those discussions to other regional authorities, other settings, to understand how our data, your respective data, fits in, how it can complement the bigger picture? So trying to understand whether those advancements happen within the organization or whether there's any thought as to how those advancements can help you better integrate with the rest of the system. Thank you.
Any thoughts or reflections? We'll start with Evelyn.
It sounds like a good idea. I don't know if I would have much to add to that, but I mean, is it fair to say the question is centering around a little bit like how much bottom-up thinking should we be doing versus top-down direction of what things should look like?
So I guess the idea is the John Kennedy type of approach is ask not what the data can afford, but what they want data for the rest of us.
Yeah, I personally am, kind of like that approach. I also think, despite the fact that a perfect future for all was like, we have these like national data standards for certain things, but I do think that maybe if we do start to approach, if we lean into the fact that Canada will always be, multi-province, multi-territory, and we think of ourselves more like a, European health data space, then maybe it benefits us to be thinking more bottom up and less top down. We need everything to tie up with a bow nationally, but I do like the idea that local, regional learnings could be applied at minimum to like provincial coordination. I don't know, what do others think?
And I know there is an international colleague speaking a little bit later on one of these sessions, stuff like that, where I know we could learn a lot from that session as well too. Peter.
Yeah, I think there's a lot of really good examples of innovation out in Ontario. Like, for instance, I'll just pull an example, Humber River with their control center, command and control center that they've built. And I know a lot of other hospitals go and visit them to learn what they've done, implementing algorithms into their dashboards too. And so I think there's tons of room for that. And the news spreads, the best practice spreads. And I think I've started a community of an analytics community of practice recently as well, and there's a lot of knowledge sharing and learning that happens there around best practices, data quality improvements, et cetera. So I think creating something like that helps to spread the best practice as well.
Paul, last words.
Yeah, I think it would be interesting to see what lessons are learned in other provinces. I'm mindful, notwithstanding Deepak's comment earlier that the funding formula is shut off right now. The funding formula context has driven our approach to data in Ontario. And a lot of the decisions along that way are still kind of driving how our data is organized and structured. Other provinces, we know they haven't gone the same path of having that data-driven funding in the same way. So it would be interesting to see what we could learn from that.
Yeah, is that a good thing or is it a bad thing, right? We don't want to pass judgment on that. But anyways, I see we're over time. So again, thank you very much to our panelists.